Dr. Gordon Macdonald is the Chief Executive of Care Not Killing, the UK's leading anti-assisted dying campaign group. Morning, Gordon.
Good morning.
So still no concrete recommendation on whether assisted dying should be legalised or not in this report. They just want to stimulate debate. Presumably you would have liked a concrete recommendation.
Yeah, we think that in view of the negative stories that are coming out of places like Canada, where people are being offered assisted suicide or euthanasia because they have to wait too long for treatment, or because they can't get access to support for disability issues, because of those sorts of stories, and because of the fact that the numbers just get out of control in every jurisdiction where the law is changed, and vulnerable people are put at risk, then the committee should have come down and said that it's just not safe, which is what the Danish Ethics Committee actually concluded, that you can't have a safe system of regulation.
And why is that? Is that not just about setting your parameters very carefully and keeping to them?
Well, the problem is that the parameters are not kept to. Even in Oregon, the law has been expanded to include non-residents. It's been expanded with the waiting period being waived in certain circumstances. And we know that only 1% of people who have an assisted suicide death in Oregon actually get a psychiatric assessment, even although probably 25% of them are depressed. So the issue, I think, is that even in the tightest jurisdictions, there are still real concerns.
What's the issue with them being depressed? Sorry. Would you not expect people who are in sort of terminal pain to be depressed?
Well, I mean, people largely don't have to be in terminal pain. Pain is one of the lowest reasons that people actually seek an assisted suicide in Oregon. It's more issues like feeling being a burden on their family or on their friends, or just not enjoying life because they can't do the things they used to do, or just wanting to be in control. So it's existential issues and people struggling with death, actually, rather than the lack of access to proper palliative care. But I mean, depression is common in terminal or chronic illness, of course it is. But the way we treat depression normally is to address the depression rather than help people in their lives. And the reason for that is because depression is a sort of temporary condition that can be improved upon, and we can help people's quality of life to improve as a result.
Yeah, I suppose quality of life is the key thing here, really, isn't it? Because we know that we can and have over years, certainly in almost every part of the world, lifespan has increased over the years, although it's kind of tailing off a bit now. But health span, so the amount of time that you are well and living a healthy life is not matching up with lifespan. So you've got this gap. And what do you do with that? Because if your palliative care is not good enough or not well funded enough, then you've just got people having a really miserable end to their life.
Well, I think there's various challenges there. One is the funding of palliative care. Actually, we have seen in jurisdictions where the law has changed that palliative care is deprioritised compared to those countries where it's not changed. So there is an overall increasing demand for palliative care because we have more people dying.
Yeah,
that's likely to go up by 25% by 2040 per annum. And we have, at the same time, a financial challenge in palliative care where current funding provided by the government only covers 30% of hospice care, and it's not even keeping pace with inflation and increasing staff costs. So we have a perfect storm for palliative care at the moment. So and this is where the committee has actually come out with some very good recommendations, because they've recognised that and said the government needs to become serious about funding palliative care. But in terms of the wider point that you made, fundamentally, we either value human life and say that it's worth preserving and respecting, or we come to the conclusion that some people's lives are not as valuable as others because of their quality of life, and that's an extremely dangerous place to go as a society. We saw it a bit during the COVID pandemic, of course, where people were either moved out into care homes without being tested for COVID, or alternatively, were having do not attempt cardiopulmonary resuscitation orders placed on them without their knowledge or consent. And that's very worrying.
But without their knowledge or consent is obviously the big problem there, isn't it? Because that's not what we're talking about here. We're talking about people who are saying themselves that they would like to end their lives.
Well, that is the problem. But the fundamental cause of that was a mindset that was creeping into the NHS, which was that we and it's understandable why it happened in the circumstances of a healthcare crisis, but it didn't make it right that, that we prioritise some people over others. And if you have stretched resources in the NHS, which we clearly do, and the NHS is in a crisis at the moment, and then you introduce assisted suicide or euthanasia on top of that, then the danger is that doctors just come to essentially apply subtle or even overt pressure on people to end their lives when they wouldn't want to.
I just want to go back to something you said about the palliative care sort of being deprioritised in places that have allowed assisted dying, because that's not what the Health and Social Care Select Committee have said in this report. They've said that it hasn't become worse. Palliative care, end-of-life care hasn't become worse in those places. And in some cases, it's led to better support with more money being invested.
Yeah, what they said was they hadn't seen any evidence of it, but all they needed to do was look at the all-party parliamentary group for Dying Well's website, and they would have seen data that shows that, yes, there has been an increase in investment, but the increase in investment is not as high as in those countries which haven't legalised assisted suicide or euthanasia. And, the context is of increasing demand, of an increase of perhaps 25% by 2040. So in real terms, you're probably seeing a decline. That's the point. And that, I think, is a shame that the committee didn't really get into that level of detail, which is what they should have done, I think.
If as you've described here, there is a massive issue with the funding of palliative care. And if that funding isn't available, what do you propose we do?
Well, I think the fundamental problem is the approach to the NHS, to be honest, and within the NHS, because we have an NHS that is focused on what one of our medical colleagues calls fix-it medicine, which is high-cost interventions, which, in an acute setting, which benefit fewer people, whereas all of us are going to die, and all of us, or 80% of us, or 90% of us, will need palliative care in some form or another. And yet only 30% of hospice care is funded by the NHS, and in out of hours and at weekends and in the community there's often huge gaps, and that's why we sometimes have people having difficult deaths. So we need a refocus and a reprioritisation on both on primary care such as GP services, but secondly on properly funding palliative care, and that may mean difficult choices for politicians about some of the other things that they're currently spending money on.
We heard from Esther Ranson there. She signed up to Dignitas and she's campaigning on this issue. What would you say to her?
I think obviously we all feel sorry for Esther and for everybody in that situation. But what we do find is, and this is tested time and time again and testified to by palliative care doctors, is that when people actually have proper palliative care, specialist palliative care, that wish to die is transient and goes away. And looking at Dignitas, there's not that many people from the UK go to Dignitas every year. I think it was about 30 last year. And that's obviously tragic in those circumstances. But, we have to bear in mind that if we change the law, we will be talking about hundreds or thousands of people feeling pressurised into this option to end their life prematurely. And that's not a good thing for the country or society to do.
It's a really interesting conversation, and a conversation that we clearly need to have. Thanks very much for your time, Gordon.
Thank you so much. Bye.
That's Dr. Gordon Macdonald, Chief Executive of Care Not Killing, who are the UK's leading anti-assisted dying campaign.